How are you,
Doing well.
Christopher?
Thank you for having me.
It's a pleasure. When did you come from Virginia?
I came yesterday morning.
We can tell the public you are the past president of the American College of Cardiology. And why did you come to Uruguay? What is important for the American College of being the past president here in our meeting?
We have, it's called the American College of Cardiology, but it's an international society, and we have 47 chapters now around the globe, including Uruguay, and it's an important chapter here. And you've been a past governor of the chapter, and we send a representative of the ACC here every year to participate in this terrific Congress and to maintain our relationship. And we had a combined session yesterday on cardiomyopathies.
Thank you very much, and it's very important for us that you came, and personally you come, and the ACC sends speakers. And what do you think for a Uruguayan cardiologist is important to be part of the ACC?
Yeah, I think, as I said, it's a global society. ACC has tremendous amount to offer international members, from education, online education, in-person education at the annual ACC meeting. We have ACC regional meetings. ACC Latin America this year is in Medellin, Colombia. So a regional meeting where members from Latin America come, and we have that regional meeting every year. To participate in our global registries, we have heart attack registries called GATI. We have quality solutions. We also have NCD Academy, which is a free online education about non-communicable diseases. So all this material is available to members from Uruguay and other countries around the world.
And if an Uruguayan cardiologist want to be part of the society, which are the mechanisms to be in part?
Yeah, so you go
members.
To go online. In fact, if you're under 40 years old, the membership now is free. There is going to be that's going to change as January 1st, 2027. But during 2026, for under 40, membership is actually free. And one thing I didn't mention is also availability of all of the JACC journals, which now comprise 10 journals, not only the parent JACC, but 9 sister journals, which all have high impact factors.
Very well, thank you. In that aspect, we know that you are a specialist in myocarditis, particularly in hypertrophic myocarditis. What do you think is the new things that you are showing? You are a journalist too, so for the cardiologist, which is the important remarks of the things that are coming, the megacactain and all the new. What do you think will be the?
Yeah, so two new aspects to discuss. One is the hypertrophic cardiomyopathy registry that Stefan Neubauer from Oxford and I have been co-principal investigators for the last, started recruitment in 2014. So the last 13 years, and we published just recently the main outcomes paper of this registry in the Journal of the American Medical Association just last week. And what we found, we studied 2,750 patients with hypertrophic cardiomyopathy from 6 countries around the world, 44 sites, and we followed them for a mean of 7 years. And at baseline, in addition to a comprehensive questionnaire, each patient underwent a cardiac magnetic resonance imaging session, as well as a blood draw for genetics and biomarkers. So it's the largest comprehensive phenotyping study of HCM ever performed. And what we showed is that predicting the composite endpoint, which included arrhythmic events, the HCM-related deaths, arrhythmic deaths, heart failure deaths, and other arrhythmic and heart failure events. And there were such events in 104 patients. There were 5 predictors of adverse outcome. 3 of them were identified by cardiac MRI. Those included, most importantly, scar in the heart, as identified by late gadolinium enhancement. The extent of scar, more than 9%, was an important predictor of adverse outcome. Left ventricular mass index, left ventricular end systolic volume index. And then there were two other markers. One, a clinical history of heart failure was predictor of the heart failure events. And lastly, the log of the biomarker NT-proBNP was for the first time shown to be an important predictor of outcome. So our next step is to develop a predictive risk score from this model that we've developed and then test it against other populations.
This is a very important message for our country. MRI in Uruguay is still not free for everyone. We are trying from the society to fight that it will be free. What other areas like ischemic cardiomyopathy do you think is important in MRI?
Yeah, let me go back to the other important area in HCM, and then I'll answer that question. So you mentioned the cardiac myosin inhibitors, mavacamten and aficamten now is FDA approved as well in the US. These are two very powerful therapies for obstructive HCM, very effective in improving symptoms and reducing the gradient. And now, for the first time, aficamten has been shown, though it's not published yet, but the top-line results have been released by the company showing that it is effective in non-obstructive HCM. So for the first time, we have a therapy to make patients with non-obstructive HCM reduce their symptoms. This is really the first of its kind in non-obstructive HCM.
Excellent. And what is the relationship between, what is the role in the future to surgery of obstructive myopathy?
Certainly, the role of surgery is a bit diminished because of the effectiveness of these CMIs. That being said, there are patients who, for reasons of economics, insurance coverage, whatever, can't take a CMI or for whatever reason don't tolerate them, although I would say the vast majority of patients tolerate them fine, or they fail the CMI. There are a few percentage of patients that don't respond. So those patients will be surgical candidates. But I will say that even though the percentage of patients who undergo surgery has gone down, we're still doing plenty of surgeries because the recognition of the disease has increased with the availability of these new medications and improved echocardiography and improved awareness and education. We're identifying, we used to see only the tip of the iceberg, but now we're starting to see the iceberg below the water, and there are many more patients being identified. So even though percentage-wise the number of surgeries may go down, the absolute number is maintaining because so many more patients are coming out of the woodwork.
And this new therapies, what is in the long term, what information do you have?
Yeah, so there's emerging long-term data. Now, mavacamten, there's a long-term extension studies. Now there are patients who've been on it for 5 years, and the benefits are maintained with no added risk over that long-term time frame.
And if this retire the therapy, it maintains that?
Yes. In fact, I looked at an MRI just 2 days ago of a patient who's been on mavacamten for 4 years, and their heart looked completely different because there's reverse remodeling. The wall thickness and the LV mass regress, the left atrial volume thickens. If you showed me the most recent echo, I may have difficulty saying that was HCM until I saw the late gadolinium enhanced images because there was scar in the heart. So it's really changing the morphology, affecting the muscle directly.
That is plain and excellent. And what are other areas of expertise that you have?
Yeah, cardiovascular imaging is my main, especially cardiovascular MRI. You'd asked about the role of CMR in ischemic cardiomyopathy. I think viability imaging is a strength and certainly identifying scar. There is some controversy around the utility of viability imaging. How do we use it at our institution? We use it in patients with very low EF to help the surgeons decide who is going to have trouble coming off pump. If there are multiple regions of transmural infarction, very little viability, that's probably a patient who's a poor candidate for coronary artery bypass grafting because of the likelihood of having difficulty coming off bypass.
Yes, that's excellent. I was recently asked to write a part of a written from the surgery committees of ACC about viability, and the new strategies for viability are very important. The MRI seeing the concordance between resonance and between vascularization. And what do you think is the future of MRI and viability? Is the functional with dobutamine? What is the areas that you think are more important in that area?
Yeah, so that's an area I've actually directly studied. Turns out low-dose dobutamine response is likely more accurate on a segmental basis than just the late gadolinium enhancement. But again, does it really matter when you're deciding on whether a patient needs to go to bypass? In my mind, the key points is does the patient have ischemia? Do they have angina? Do they have ischemia? And do they have enough viable myocardium that they're not going to have trouble coming off bypass? So, can argue about, how many segments or what have you, but I think it's symptoms, ischemia, and some viability.
Yes, we as surgeons look at it. If you have a bad function, but you have a good target vessel, and there's not a big myocardial scar, we'll go to surgery. The problem is the gray area of the gray patients risk. Well, then it's very fun to hear you. And then another area that we want to discuss is we know that you talk about the new Latin American area. We all meeting to be where you say Medellin.
Medellin.
Well, it's very important that we will try to promote it here, and in the future we always talk about having an ACC Latin American here in Uruguay, and the people are listening, perhaps being part of ACC and we part of making a Latin American meeting joined with the Society of Cardiology. Well, very good, and we hope that you like our city, and a final message for us.
Very much appreciated the warm hospitality and warm greeting I've had here in Uruguay, and it's a terrific meeting. It's been a pleasure being a part of it, and I just encourage your members to consider joining the American College of Cardiology. There's a lot to gain from being a member of the ACC and working together towards improving heart health for all.
Very well. Thank you very much.